I just want to recognize members of the Scientific Advisory Board that are here. Brian Rood is over there somewhere. Is Brian? Dr. Christine Proteus is right there. Dr. Aykut Aren is right here. And we're waiting. Dr. Wiedemann, Brigitte Wiedemann from the NCI will be here this afternoon. And I think Drs. Fixler, Kwok, and Peterson, Dr. Peterson is on her honeymoon, so that's a good excuse for not being here, right? Aren't able to make it today. But thank you, and thank them for all their support in reviewing abstracts and helping throughout the day in various roles that you'll see. One of the goals that I had when putting this together, as somebody who was supported by CCF since 1995, that there was great research going on in our little community here in the Baltimore, D.C. corridor, and there wasn't enough connectivity and awareness of what each of us were doing locally, and it's so helpful to meet people locally, and you can go to the big national meetings, but this is, where if you really have a great idea and you want to put something together, you can drive 30 minutes, 40 minutes, and sit and talk about these things, which is, I think, really important. As an example of that, probably about 10 years ago now, CCF had funded a grant for David Loeb at Johns Hopkins on cancer stem cells. And I happened to hear about that sort of serendipitously. And there was a request for proposals from the NCI for stem cells were hot back then. That was before immunotherapy. And so I got in touch with David because I thought we had the right elements for this grant, and we did. We spent 5 years with an R01 together doing some really cool work, and it was because we made a connection through CCF. So I think I'd encourage you today to take time to meet people at the other institutions, and as my patron saint, Ms. Frizzle, would say, take chances, meet people, and welcome. And with that, I think we'll get started. So it's a pleasure to introduce Dr. Srivandana Akshintala from the NCI. She's currently a staff clinician there, although she did her fellowship here locally at Children's National Medical Center. And she's going to talk to you about sarcomas, clinical overview, and novel treatment approaches, following which Tasha will introduce Danielle Henke. So.
Good morning, everyone. I'd like to start by thanking the organizers of the Children's Cancer Foundation Research Symposium for giving me this opportunity to present and start off the morning session. The task given to me, as was mentioned, is to provide a clinical overview of sarcomas and discuss novel treatment approaches. I'll definitely not going to be able to do justice to this very heterogeneous group of cancers in the short amount of time that I have. And this is especially true, I think, as we are recognizing more and more, not just how each type of sarcoma, but even the subgroups within the different types of sarcomas are their own unique snowflakes, no two alike. And, but what I do hope to do is to just provide a very brief overview and set the stage for all the amazing talks that are scheduled for this morning, as well as the very exciting plenary session by Dr. Groher. So what are sarcomas? They are a rare, diverse group of cancers arising from the bone and connective tissues of the body. They account for around 12% of all the cancers seen in children and adolescents, that is under 20 years of age. About like 1,700 cases of sarcomas diagnosed every year in the US in this age group. And despite cancers in general being much more common in adults, sarcomas remain a rare malignancy because even there, they only account for about 1% of all the cancers in adults. And this rare group of cancers gets even more challenging to study and manage when we recognize that this is not just one disease, but it's made up of more than 70 different histological subtypes, and which are typically classified based on what we think is the cell from which the cancer originated from, such as liposarcoma, arising from the fatty adipose tissue, and fibrosarcoma from the fibrous tissue. And the figure here kind of just gives examples of a few different types of sarcomas to highlight the same. And all of these subtypes, they differ in how they look under the microscope as their pathology, what molecular changes we commonly see in them, as well as their clinical presentation, including age. So some of the cancers are more commonly seen in adults, while others are a lot more common or predominantly seen in children. So specifically focusing in the pediatric age group, the most common bone cancers we see are osteosarcoma and Ewing sarcoma. And rhabdomyosarcoma is the most common soft tissue sarcoma, making up around half of the soft tissue sarcomas that we see. And a group of other soft tissue sarcomas, such as synovial sarcoma, alveolar soft part sarcoma, malignant peripheral nerve sheath tumors, amongst others, make up the remaining half of soft tissue sarcomas that we see in this age group. These cancers can develop anywhere in the body, and many a times presenting with a mass, sometimes with pain, and the signs and symptoms will differ based on the type of cancer, the type of sarcoma, and its location. Scans, pathology, and molecular studies, especially in the case of sarcomas, as many of them have very specific translocations, help us figure out the diagnosis and subsequently stage the cancer and figure out the risk group, which helps us determine what the best treatment approach is. Standard treatments, traditionally, the treatment for sarcomas has included some form of local therapy to the site of the tumor with surgery and/or radiation. And especially for most pediatric sarcomas, the treatment usually also includes chemotherapy. I highlight here in purple the 4 traditional chemotherapy drugs that are FDA approved for treatment of sarcomas, although there is a whole bunch of other chemotherapy drugs, and I've listed some of the common ones there that we also use typically in different combinations as part of standard treatment. So, with our standard tools of chemo, surgery, and radiation, we have some success treating especially like the localized forms of sarcomas or the sarcomas that can be removed by surgery and those with more favorable risk features. However, outcomes for patients who present with either unresectable, metastatic, or recurrent disease remain very poor. And as you can see in the survival curves shown below of the 3 most common types of pediatric sarcomas, Ewing sarcoma, osteosarcoma, and rhabdomyosarcoma, we haven't made a lot of progress when in the setting of the metastatic disease. So given limitations of standard treatment, there is a great need for novel treatment approaches. And more recently, we've been trying to add to our standard toolbox by studying other approaches, including targeted therapies, which are either small molecules or antibodies that target the enzymes or cellular pathways of the cancer cell. Immunotherapy approaches, either by cellular therapy ways of CAR T cells or TCR-based or other types of immunotherapy approaches. Trying to use newer approaches for delivering drugs that we know work, as well as novel image-guided approaches for treatment. And some of these approaches have shown success, as shown in this table of the more recent FDA approval for different sarcomas. Imatinib, a tyrosine kinase inhibitor, a form of targeted therapy, was first of these drugs to receive approval for GIST, a type of sarcoma seen in the gastrointestinal system, followed by its approval for a different sarcoma called dermatofibrosarcoma protuberans. Pazopanib, which is another tyrosine kinase inhibitor, was then approved for adults with advanced soft tissue sarcoma who had received prior chemotherapy. In the past decade, many other drugs have now received either full or accelerated approval for different subtypes of sarcoma. And I highlight here in blue where the approval includes the pediatric age group, such as atezolizumab for alveolar soft part sarcoma, which is approved for children's age 2 and above, and larotrectinib for tumors that have NTRK gene fusions, which is seen in over 90% of patients with infantile fibrosarcoma, a very rare type of sarcoma seen in very young children. In addition to these approved drugs, preclinical and clinical studies continue to study all these different approaches and how best we can combine them to tackle this challenge. And just as an example, I will mention today about 2 of the studies that I have been involved with. The first is a targeted therapy approach, and the second is an immunotherapy approach with CAR T cells. The first example is the story of multi-target kinase inhibitors in bone sarcomas, using cabozantinib as an example, which is a receptor tyrosine kinase inhibitor that targets MET, VEGFR2, RET, and AXL, amongst others. Receptor tyrosine kinases are implicated in the pathogenesis of many cancers via activation of downstream signaling pathways which control cell growth, migration, and proliferation. Based on the preclinical evidence of activity, trials have explored the activity of many different tyrosine kinase inhibitors in osteosarcoma and Ewing sarcoma, including cabozantinib, regorafenib, sorafenib, lenvatinib, and others. Specifically for cabozantinib, we conducted a children's oncology group phase 2 trial of cabozantinib to assess its activity in children and young adults with specific relapsed refractory solid tumors. The study had different solid tumor disease strata and included 4 sarcoma cohorts: osteosarcoma, Ewing sarcoma, rhabdomyosarcoma, and a cohort for non-rhabdomyosarcoma soft tissue sarcomas. And based on the disease control success that was observed at rates that were higher than what had been seen historically, the study concluded that cabozantinib is active in patients with relapsed refractory osteosarcoma and deserves further study in this disease. The French sarcoma group also conducted a multi-center phase 2 trial where they enrolled adult patients with advanced bone sarcoma, and they saw that cabozantinib has activity in patients with advanced Ewing's and osteosarcoma. And based on this, cabozantinib is now being studied in the upfront setting in combination with cytotoxic chemotherapy as part of a children's oncology group randomized phase 2, phase 3 study for patients with newly diagnosed osteosarcoma. Next, I wanted to briefly mention another study that Dr. Rosie Kaplan at the NCI is leading using CAR T cells targeting GD2 in patients with osteosarcoma and neuroblastoma. CAR T cell therapies use genetic engineering to harness the specificity of a monoclonal antibody with the cytolytic capacity of a T cell. Thus far, responses to CAR-based therapies for solid tumor have been less impressive than what has been seen for heme malignancies. T-cell exhaustion and more suppressive tumor microenvironment are some of the possible reasons for that, amongst others. GD2 is a sugar lipid, a disyloganglioside, which is highly expressed in osteosarcoma. And the figure there shows the immunohistochemistry staining of the high expression of GD2 in osteosarcoma, which has been seen in many studies. And preclinical studies of GD2 CAR T cells have shown promising activity, based on which trials of GD2 targeting CAR T cells have been conducted in osteosarcoma and neuroblastoma. These studies showed robust CAR T expansion without toxicity, but unfortunately, we didn't see significant responses. And the GD2 CAR persistence and expansion were not improved by adding additional immunotherapy with checkpoint blockade. Work done by Dr. Crystal Makel and Dr. Kaplan and their team showed that these T cells had an exhausted phenotype, which limited their function and their efficacy. And this information was used to design newer CAR T cells, which is now being used in the current study. This CAR has a 4-1BB co-stimulatory domain and is manufactured with IL-7 and IL-15 in presence of dasatinib. This is still early, and it's a phase 1 study which has a dose escalation cohort where the objectives are to see if we can successfully, feasibly manufacture these CAR T cells and also figure out what the safe recommended dose is. And if that is successfully accomplished, the study moves on to the expansion phase where we will try to at least preliminarily assess what the response rates are and what the duration of response is. Key eligibility is that patients should have relapsed or refractory osteosarcoma or neuroblastoma. And the dose escalation cohort will be enrolling cohorts of 3 to 6 patients who will receive the CAR T cells at different doses to try to figure out what the best safe recommended dose would be. And once the dose escalation part is completed, there will be expansion cohorts, one for osteosarcoma and one for neuroblastoma. And similar to other CAR T-cell studies and treatments, the process involves the patient has to undergo apheresis, where their autologous, their self T-cells are collected. Then the cells get shipped to a centralized facility for manufacture of the T-cells. And once that is done, the treatment portion of this study begins, where they receive chemotherapy to prepare their bodies to receive the CAR T-cells, get the CAR T-cell infusion, followed by monitoring for both toxicities as well as for response from the therapy. So in summary, although we still have a long way to go to significantly improve the outcomes for many of our patients with sarcomas, I do think there is much to be hopeful about as we continue to build on our understanding of sarcoma biology and try to figure out how to leverage that knowledge to improve treatments and outcomes for our patients. There are many different approaches, including targeted therapies, immunotherapies, amongst others, that are being explored. Clinical trials are being conducted, and more for histologically or molecularly defined subtypes. And given the rarity of many of these subtypes, these are being done with a lot of collaborative effort and innovative trial designs. And despite the challenges of being rare cancers, several new drugs have been approved in the past decade, which I hope is only the start of many more successes. And with that, I would like to thank you all for your time, and especially thank our patients, families, and advocates who inspire us every day to keep doing better, my teachers, mentors, and colleagues, many of whom are in this room, who have taught me most of what I know, and our donors and supporters who make a lot of this work possible. Thank you.
So we have time for a couple of questions. If you have a question, there's roving microphones. Just raise your hand and they'll come find you. Questions? Anybody? I'm going to ask a question if you don't. Yeah, I'll ask a question here. So one of the challenges we've faced in new therapies is the challenge of overcoming toxicity, because with a lot of our patients with localized sarcomas, we're achieving cure at what I would say is it's a reasonable, it's not acceptable, a reasonable rate, but they have a lot of toxicity. We know a lot of late effects. And so as you're working at the NCI in creating new therapies, how do you guys think about in terms of a new therapy and its impact on toxicity compared to existing therapy?
I mean, that's a very important, but also a very big, broad question, I guess. And I don't know if I have a straightforward answer. I mean, we are always, of course, always cognizant that a lot of, as you said, even it's just about acceptable, not great successes, even in the localized or favorable settings, but that does come at a very big toxicity component. And I think right now we're still trying to come up with better or therapies that even work in the settings where things aren't really working great. But it is a very, very valid question that once, if we do start seeing successes, how do we, move it up front or figure out better ways to, treat it in a setting where we may have successes, but it's coming at a great toxicity. I guess one example I could think of would be for larotrectinib, which, again, it's a very, very small group of sarcomas that it's being looked at. But, for infantile fibrosarcoma, treatment was traditionally surgery. In many cases, it would work, but not about half the patients. And then they would get chemo, and these are very small babies, infants, and it would come with significant toxicity. And now there is a study looking at it in an upfront setting, trying to see if larotrectinib, which has shown dramatic response rates in the relapse setting, could that actually do the same and be able to do better in the upfront setting by minimizing toxicities. So I think there are glimmers of hope with all these very tiny subgroups that we are trying to make some progress. And that's part of why I started out with my figure with all the snowflakes, because I am thinking more and more we have to start seeing them as these individual unique things, and if we can come up with like something specific that works for these, each of its unique, what is its own problem for that particular sarcoma, we may be able to then be creative in how we can treat them better by being more specific or targeted for that particular tumor, rather than, right now where a lot of them get treated with a very generic group of chemotherapies.
Does that stimulate any other questions amongst the audience? Because if not, I have another question. I love asking difficult questions. So you mentioned that we are looking at sarcomas now more uniquely based on their snowflake, based on their characteristics. And now we're sequencing a lot of these, and so we're getting a lot of genetic information. So how do you see this genetic information now being overlaid with some of the therapeutic opportunities?
I'm hoping a lot of the following talks will kind of like, I guess, throw more light to this, but I think it's the same. Some of them, like osteosarcoma, I know is very challenging, so we have to start thinking it differently, but, and I think Dr. Groher's here, and I'm hoping he'll talk about his study during his plenary session, and your work too, like, where Ewing sarcoma, where when we know there is a very, unique translocation that seems to be the sole oncogenic driver for this cancer, of studying how it is causing it and what we can do to specifically target that, which has been a work of many smart people here who know more than me. And I do think we are starting to see some successes there. It is still early, and I know we have a long ways to go, but I'm hoping over the next few years that's where we'll be headed.
Thank you very much. Thank you. So, yeah, just to be fair, those are questions that all of our field should be facing. Those are difficult questions, but I hope as we go forward, we actually think about those kind of things.